From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Ade Adamson, the web editor for JAMA Dermatology and host of this podcast episode. Measuring treatment response is central to the care of patients with skin disease and can be measured from either the clinician or the patient perspective. Clinicians routinely rely on clinical signs and objective scores to judge whether therapy is working, while patients may focus on symptoms, quality of life, and the day-to-day impact of their condition. Although these perspectives are closely related, they are not always aligned. And in some cases, a treatment may appear successful by clinical measures, but fall short of a patient's expectations or lived experience. In a new study in JAMA Dermatology, researchers aim to identify factors associated with discordance in clinician and patient-reported treatment response assessments and to evaluate the association of these measures with survival among patients with cutaneous chronic graft versus host disease, also known as GVHD. Dr. Emily Baumrin is a board-certified dermatologist and assistant professor of dermatology and medicine at the University of Pennsylvania in Philadelphia. She's a senior and corresponding author of this work and is here to discuss the findings. Welcome to the podcast, Dr. Baumrin.
Thank you so much for having me.
And I hear you're also a listener of the podcast as well.
I am. I listen diligently on my walk to work.
All right. Now you're one of our featured guests. I'm really, really happy that I'm finally able to get you on the podcast. You do a lot of great work in the medical dermatology space.
Thank you.
And for those people in the audience that may not know you or your work, can you tell us a little bit about your clinical interest, your areas of study, and the balance of clinic and types of patients that you see, the type of research you do?
Great. So at the University of Pennsylvania, my current role is about 25% of my time spent seeing patients, and that involves directing and attending in the graft versus host disease subspecialty clinic in the Department of Dermatology, where I both see patients on my own and supervise residents. And then I also am an inpatient consultant on the dermatology hospital service, where we see complex patients, many of them who've received stem cell transplantation and have cutaneous complications thereafter. And then about 75% of my time is spent doing what I say is patient-oriented research, which involves different methods, including epidemiology, outcomes research, qualitative research, and even more recently, some implementation science. And this is all in the area of graft versus host disease, trying to improve outcomes for these patients.
What got you interested in graft versus host disease?
It's a great question. So actually, I did combined internal medicine and dermatology training. And during that time, I was able to be a resident on the bone marrow transplant inpatient service from the internal medicine side. And I just became really compelled by everything these patients went through and all of the complications that they had to endure after curing or beating their cancer. And it really spoke to me to be able to improve quality of life after such an enduring process. And so when I got to the University of Pennsylvania, there was actually a need to see these patients. And I worked closely with the bone marrow transplant program to see their referrals for both GVHD, but other cutaneous complications after stem cell transplantation.
So patients with GVHD have a lot of sequelae related to their transplant. Why did you find it important to do a study related to patient-reported outcomes in this patient population? Was there a need to get a better sense of how useful these are in this population? What motivated you to do this specific project?
There are two angles that we can come on to rationalize why we looked at PRO specifically. The first is simply the health-related quality of life impact of cutaneous chronic GVHD, and this has been demonstrated in multiple epidemiologic studies looking at various measures of symptoms or quality of life, that patients with skin chronic graft versus host disease have great morbidity from the skin disease itself. And so this is a critical outcome measure in terms of deciding whether treatments are working or not. But in addition to that, and really specific to chronic GVHD, we often wonder whether the clinician's assessment is sensitive enough to detecting meaningful change for patients. We look at the skin and we get an estimation of the body surface area involved. Maybe we feel for the depth of sclerosis if patients have the sclerotic form, but it's quite a crude measurement. And we see this in clinical trials because the skin response measures by this clinician-reported outcome measure are often quite low. And the question is, are patients really not getting better? Or are we maybe not detecting benefit by our crude clinician measures? And so in that way, I wanted to look at patient-reported outcome measures to see how they compared to clinician-reported outcome measures in measuring therapeutic benefit.
So you were worried that the clinician-centered outcomes perhaps were not doing a great job in tracking with outcomes that patients felt were improving. Am I getting that correct?
That's right. Yeah.
And so how do you go about studying something like this? GVHD is an uncommon diagnosis, and in order to make assessments about a population, usually you have to have a larger number. How did you go about finding the data for this study?
This is a great question, and one that comes up with a lot of our complex medical dermatologic diseases, whether it's pyoderma gangrenosum, Sweet syndrome, and in my case, chronic graft-versus-host disease of the skin. And we've been so fortunate in this disease to have a consortium of academic centers and investigators that have gotten together to study GVHD, both in observational studies and in interventional trials. And this consortium is called the Chronic GVHD Consortium. And it's a group of academic medical centers and investigators, both in the United States and Canada, that conduct observational studies and interventional studies in chronic GVHD. And this allows us to have a sufficient patient population to detect meaningful outcomes in our patients.
So in this study, it appears as though you took data from 2 observational trials as well as 1 randomized control trial.
That's right. So this was a secondary analysis or an epidemiologic study of already previously collected data. And we used 2 observational studies, longitudinal cohorts of patients with chronic GVHD that were designed to examine natural history, and a randomized control trial of 2 therapies, imatinib and rituximab, for the treatment of sclerotic chronic GVHD of the skin in particular. We combined these patient groups and had our own inclusion criteria of adults greater than 18 years old and those who had cutaneous chronic GVHD by NIH consensus criteria.
And so I'm assuming that at baseline and probably throughout the study period for these 3 cohorts, that patient-reported outcomes and clinician-reported outcomes were both assessed across these studies. Is that correct?
That's right. So one really unique and nice thing about having a consortium is the studies are all designed collecting the same disease assessments and outcome measures at similar intervals. So for all of these 3 studies, clinician-reported outcome measures and patient-reported outcome measures were collected at baseline and every 3 to 6 months for 3 to 5 years. And then long-term outcomes, including mortality and relapse, were collected for many years thereafter, including for the 2 observational studies up until the present time.
And would you mind telling the audience what were the specific outcome measures that you were interested in collecting, both on the patient side as well as on the clinician side?
This study was novel, and we actually used a single global question that was reported by both patients and clinicians that asked the patients or the clinicians to rate how their skin chronic GVHD had changed from 3 to 6 months prior on a scale from resolved to very much worse. And the reason that's unique is this is asking the same question of patients and clinicians, allowing direct comparison. Prior studies have demonstrated that PROs, or patient-reported outcomes, and clinician-reported outcomes may not correlate well in chronic GVHD. But they were using very different instruments. As I mentioned before, the clinician-reported outcome measure includes body surface area and depth of sclerosis, while the patient-reported outcome measure focuses on symptoms like itch, sores on the skin, tightening of the skin. And so we expect in some ways for those not to correlate perfectly. However, when we use a single question, that's the same global question asked of patients and clinicians, it's much easier to measure discordance or a mismatch in the perception of treatment response between clinicians and patients.
And so what I'm hearing is that what you're interested in trying to figure out, hey, if there's a mismatch between the two, how does that mismatch then also correlate with the patient reported outcomes as well as the clinician reported outcomes? And can you glean from that whether maybe there's also some outcome differences in terms of survival? And that's kind of what you were trying to get at.
That's right. So we had 3 goals for this study. The first goal was just to identify how common is discordance in skin chronic GVHD. How many patients are reporting a different perception of treatment response from their clinicians? The second was to identify what clinical factors are associated with discordance. Are there certain types of patients that are more likely to have a different experience of treatment response than their clinicians? And the final goal was to measure which treatment response measure, that reported by patients or that reported by clinicians, best predicts survival outcomes.
And so let's take those objectives one by one. And what did you find? Were there a lot of discordance?
So we evaluated almost 500 adults with chronic cutaneous graft-versus-host disease. And as you mentioned, this is a rare condition, so that's quite a large cohort for this condition. And we found that about 1/3 of patients had discordance between the clinician and the patient assessment of treatment response.
And in what direction was that discordance? Was it that routinely physicians rated improvements as less than patients, or was it the other way around? Or was it basically balanced between the two?
So we found that the direction went in both ways. So around 100 patients had what we called negative clinician discordance, which means that the clinician reported that they were doing worse than the patient reported. And about 70 patients reported positive clinician discordance, which was that the clinician thought that the patient was doing better than the patient reports. So it went in both directions.
Did that surprise you?
It did surprise us because some previous studies of clinical trials in chronic GVHD consistently demonstrate that patients actually report doing better than clinicians when we assess it by the classical endpoints. That's the NIH skin score reported by clinicians and a PRO specific to GVHD called the Lee Symptom Scale reported by patients. And we have a couple of hypotheses about why that might be. First, as I mentioned before, we think that the NIH skin score might not be as responsive to change. So when patients are experiencing some improvement in symptoms or function, the clinician might not observe meaningful differences in the body surface area or the depth of sclerosis on clinical examination. We also think that patient symptoms and function might change more quickly than fixed sclerosis in terms of the body surface area or the depth of sclerosis. And so in the short term, again, we might see a patient improvement over a clinician-reported improvement. However, in our study, we found both directions, and that's a novel finding, which we think was assisted by the fact that we used that single global question as opposed to these patient-reported outcome measures and the clinician-reported outcome measure. So we also found there was positive clinician discordance, and so that signifies that the clinician reported the patient had a better response than the patient reported. And we hypothesized this could be because the clinician found improvement in, let's say, body surface area involved or some other clinical metric, but the patient had no improvement in symptoms or functions, perhaps in other areas. And this directionality is what we see more commonly, actually, in other rheumatologic and chronic inflammatory diseases when the patient experiences less of a response compared to what the clinician experiences.
All right, so it seems real tricky then. If responses go in both ways, are there certain factors that predict which direction it goes or how to kind of use this measure to maybe understand the likelihood of discordance?
Yes, so we were interested in that question because, as I mentioned, 2/3 of patients are concordant. And that means that the clinician and the patient are aligned, and you may be able to use your intuition as a clinician to drive clinical decision-making. But we really want to understand who are the patients that are discordant so we can better ascertain the patient's perspective. So we looked at various clinical factors related to graft versus host disease. That included demographic factors, transplant factors, and then clinical factors of their disease itself, and patient-reported factors such as anxiety, depression, and other patient-reported outcomes. And we looked at whether they were associated with discordance. And we found in our multivariate modeling that presence of sclerotic chronic GVHD, or the sclerotic subtype, was highly associated with having a discordant treatment response between patients and clinicians. Patients with sclerosis were 2 to 3 times more likely to have a discordant treatment response compared to those without sclerosis.
And then finally, your team wanted to understand how all of this related to survival outcomes. Did you find a relationship between discordance and survival in one particular direction or another?
Yes. So survival is a key outcome in chronic GVHD that we might not think about with some other chronic inflammatory skin diseases. And we've done some prior work demonstrating that patient-reported outcome measures are associated with survival. But here we have an estimation of treatment response, which is unique in that it's dynamic. This is not just the severity of patient-reported outcomes or disease severity by clinician-reported outcomes at a static measurement. This is improvement over time in response to therapy. And so we wanted to look at whether that treatment response by patients or by clinicians was associated with survival first, and how they compared to one another. So we found in the total cohort that both clinician-reported treatment response and patient-reported treatment response were associated with survival. So patients who improved their skin chronic GVHD had better survival, which in and of itself is an amazing and novel insight into managing these patients. But second, we looked at the subgroup with sclerosis because we had found that those are the patients that have discordance. And so what do you go by? Do you go by the clinician report, or do you go by the patient report when thinking about prediction of long-term outcomes? And interestingly, when we looked at this subgroup, we found that patient-reported treatment response was associated again with survival. Patients who reported they did better had longer, better survival. But the clinician-reported treatment response was no longer statistically associated with survival in this subgroup. And so that suggests that in patients with sclerotic chronic GVHD who are at higher risk of having a discordant treatment response from their clinicians, that patient-reported treatment response may be a better predictor of long-term outcomes.
So what you're telling me is that the patient knows best. The patient's symptoms really drive survival, and we should keep listening to our patients. Is that a correct statement?
I think that's an excellent and correct statement. And there's a number of reasons why. I think you're not going to identify discordance unless you ask the patients, whether in a global question or in a validated patient-reported outcome measure, which in dermatology can be the Skindex or DLQI. And in chronic GVHD, we have the Lee symptom scale. Second, these patient-reported outcome measures will help you risk stratify patients for long-term outcomes, including mortality. So it's helpful in the immediate treatment decision-making, and it's also helpful in the prognostication long-term.
So where do you go from this study? Is this a case where it further solidifies which PROs should be administered in clinical trials or in the clinical setting? Has this changed how you practice and what instruments you use in your assessment of patients with GVHD?
Yes, so I think the implications of this study both reach the clinic and clinical trials. So first, clinical trials. The PROs have always served as a secondary endpoint in therapeutic clinical trials, and that's common practice. But I would argue that for chronic skin GVHD, we should be thinking about PROs as either co-primary endpoints or for certain types of interventions, even the primary endpoint. And to that, we actually ask the question of whether the PROs that we have at our fingertips are sufficient in measuring chronic skin GVHD and represent the outcomes that are important to patients living with this condition. And we developed a novel PRO called the Lee Symptom Scale Skin Sclerosis, which measures sclerotic chronic GVHD from the patient perspective. And this would be an adjunct to clinical trials for chronic GVHD, particularly involving the skin. For clinical practice, this has changed my practice. For patients with sclerosis, I administer a patient-reported outcome measure, the Lee Symptom Scale Skin Sclerosis, for my patients, and I track it over time. And when I have difficulty estimating their clinical disease severity, or I think their clinical disease severity hasn't changed by my estimation, I look at the PRO and how it's changed over time, and I use that to assist in either escalating or de-escalating therapy. So bringing PROs into clinic for this condition is supported by our study.
I want to thank you so much, Emily, for being on the podcast and being a listener of the podcast, and sharing your experience on this really important topic for this rare disease that needs a lot more work done in it. So kudos to you on that.
Thank you so much. And I do hope our work translates to other investigators and other inflammatory skin conditions that aim to improve quality of life. It's been so fun to be here with you. Thank you for having me.
I'm Dr. Ade Adamson, and I've been speaking with Dr. Emily Baumrin about discordance in treatment response assessments between clinicians and patients with chronic GVHD. You can find a link to the paper in this episode's description. This episode was produced by Daniel Massisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.